Hi everyone, my name is Ganesh, and I am very grateful to be here. Thank you for having me. Oh, it's the little, see? Thank you for that. Okay, so today we're going to be talking about moral injury in medicine and a structural approach to physician burnout. I had some amazing people to work with, Todd, Kyle, and my PI, Ricky Blusenthal, who's right here. Okay. So I'm going to give you a quick overview so you can't complain later that I didn't warn you. So we're going to start with understanding moral injury and burnout, followed by a case study. Then we're going to go into a medical model, and we'll close out with what's next. When we look into understanding moral injury and burnout, we're going to talk about what it is, when does it happen, how does it present, and who is it impacting. Same things with burnout as well. And then with the case study, we're going to talk about Mr. A. What happened, his life, and what the two physicians who were treating him had to say about it. For the medical model of moral injury, we're going to look into adapting theory for medicine. So why should we think about burnout in this specific way? And finally, to close out on a sort of positive note, we're going to talk about what happens next if we keep working on this research. Okay. Quickly, before we jump in, I want to give you a quick content warning. We're going to be discussing some heavy topics, including suicidality and death. And if that's not something you want to listen to today, I totally understand. All right. Moral injury. What is it? In extremely traumatic or unusual circumstances, people can often perpetuate, fail to prevent, or witness events that contradict their deeply held moral beliefs. And this happens in three major ways: commission, omission, and witnessing. Commission is when people participate in the event that contradicts their belief system. Omission happens when they're unable to, for whatever reason, intervene and prevent or change the outcome of the event that contradicts their belief system. And then witnessing, of course, is when they're standing by and watching something happen. So what does it look like? It looks like guilt, shame, anger, an inability to self-forgive, and also includes engaging in self-sabotaging behaviors. It's also important to note that there's a spiritual impact to moral injury. And finally, who does it impact? Majority of the literature on moral injury comes from veterans and is produced by the VA. But we here today specifically are going to be looking at physician impact. So in healthcare workers, it can look like triaging life and death cases and making resource allocation decisions, or when they think that their colleagues, or their system should have been able to intervene and save a patient's life, but was not able to do so. Burnout. Burnout is an occupational phenomenon and not a medical condition, meaning it happens specifically in the workplace and it's workplace related, which is both a good and bad thing. It means that we can intervene, but it also means that it's happening systemically. It presents in three ways: fatigue, mental distance, and a reduced personal efficacy. When we're looking at it in physicians specifically, we're looking at dropout rates, death by suicide, and which is specifically linked to EM physicians, which is emergency medicine. And they're also able to identify that burnout is systemic and related to system-based causes. I want to make note that emergency medicine physicians are significantly more vulnerable to burnout than physicians from other departments and also other professionals working in emergency medicine. This is important because the two physicians who participated in this study were emergency medicine physicians. Okay, so what did we do? We had three data sources: a patient interview, extant literature, of course, and physician reflections. So the two physicians who were treating this patient submitted reflections, and we analyzed that. How do we do this? We transcribed the patient interview and we analyzed it for structural vulnerability. Then we reviewed the extant literature for themes. We followed that up with a thematic analysis of the physician's reflections, and we closed out by developing a medical model of moral injury, which we will look at very shortly. So let's talk about Mr. A. Mr. A was born with a congenital heart condition. He found out that he was adopted when he was about 10 years old, and that was a major turning point in his life. And he described that as a point after which he started acting out and initiated substance use. When he started quote-unquote acting out and eventually went to prison. In prison, he initiated substance use, specifically heroin, and was subsequently diagnosed with hepatitis C. When he was released, he initiated street-based substance use, after which he was diagnosed with injection drug use-related infective endocarditis, which is an infection of the heart valve. He was treated surgically, but he returned to prison before he was able to make a full recovery, which he described as being really traumatic and difficult for him to handle because he was hoping to make a full recovery before he had to return to prison. Once he was back, he reinitiated substance use during his incarceration. He was then diagnosed with a DVT and a second episode of infective endocarditis. He received correctional surgery for that infective endocarditis, but again was not able to make a full recovery. And finally, at the time that this interview was recorded, he was admitted to the cardiac critical care unit for a third episode of injection drug use-related infective endocarditis, and he died because he was not offered surgical intervention this time. Major themes from the physician reflections that we saw were structural violence, institutionalized deservingness, and peer betrayal. Structural violence is, of course, an imposition of unequal risk for disease, injury, and death by social, political, institutional, and economic configurations and policies on identifiable population groups, in our case, people who use drugs and people who are incarcerated. Institutionalized deservingness is a tiered healthcare, so when specific groups and specific populations are not offered the same care that other populations are, likely due to poverty or stigma or other reasons. And finally, peer betrayal is when the decisions of a peer impact the subject's subsequently committed or omitted actions that potentially are morally injurious. So I'm going to go over some of the quotes, but not all of them, because we don't have that much time together. But to start with, institutionalized deservingness. The first one is, we had to tell Mr. A that even though the system had failed him his entire life, we were failing him yet again, and this time our failures were going to cost him his life. Another one that stuck out is, the case has stuck with me more than any other as a physician because I've never been in the situation of telling a young patient that they will die of an illness where we typically do have interventions to offer, indicating that in other circumstances, maybe the interventions would have been offered. I have questioned if I felt like the principle of justice was not honored in his final days. He was also born with a congenital condition that predisposed him to this disease, suffered from childhood adverse experiences, and had been in the cycle of incarceration and substance use. The surgeons argued that a third surgery that would be complex is not a just use of resources in a gentleman with continued IV drug use. I won't read the whole quote, but you get the gist. So structural violence in medicine was another theme. It took them 5 attempts at seeing a jail provider over the course of several weeks before presenting to us in cardiogenic shock. So essentially, when we talk about structural violence in medicine, it was really challenging for the physicians to figure out what to do because of the patient being incarcerated. For example, it took them an entire day of calling hospital and jail administration just to give his mother and girlfriend a chance to hold his hand before Mr. A passed away. This is another quote. And finally, peer betrayal. In this specific situation, they were asked to wait until his condition got worse to discuss options of surgery. And then when his condition did get worse, he was not offered the surgery. And the way they discussed it was, Within days, his condition declined and the conversation changed to discuss the merits of surgery in a young patient who had multiple failed surgeries, which, if you remember from earlier, there is a question of whether his surgeries failed or if he was not able to recover entirely. Okay. All of these extremely unfortunate circumstances led to the present where our surgeon colleagues felt like they could not justifiably offer care to this poor individual due to it being too high risk, a short-term solution, and unfair from a resource standpoint, to perform a third surgery. Medically, we had no other treatments to offer him either, and he ended up dying with our service. They say medically because these are EM physicians, so they cannot intervene beyond the point. Okay, so the medical model of moral injury states that there are certain structural drivers that can impact moral injury, and some of them we went through just now, which include leadership and peer betrayal, institutionalized deservingness, a profit-driven healthcare system, structural violence in medicine, and defensive medicine, which can lead to, of course, moral injury. Which could look like exhaustion and fatigue, low personal accomplishment, depersonalization, cynicism, and desensitization, which also happen to be symptoms that are associated with burnout. Because these are associated with burnout, this model suggests that what looks like burnout could be the aftermath of moral injury and has structural drivers built into medical institutions. And in order to address this, we should be looking at things structurally. So what's next? Because I don't want to leave you on a very, very sad note. It's important that we look at structural interventions to decrease moral injury. And that looks like structural protection. Structural protections is, too enthusiastic. Structural protections are when we as a system generate interventions that specifically protect groups that are unable to thrive in the medical system, which here in this case are people who are using drugs and people who are incarcerated. That looks like building out guidelines that restrict discretion where discretion is not clinical. Discretion is based on opinion or moral ethics and things like that. Next, we also have to build this model out because this one doesn't include physician intersectionality, and physician intersectionality can play a major role in which physicians are more or less vulnerable to physician moral injury. So, for example, based on where a physician falls in the ranking of the medical system, based on specialty and hierarchy and the silos in medicine, physicians could be more or less vulnerable to moral injury. At the same time, based on individual level factors, physicians could also be more or less vulnerable to a moral injury. That's all I have for you today. I want to acknowledge all of the amazing people that I had a chance to work with, so thank you for that. And thank you all for your time.
Okay, we have time for one question over there before we break.
Hello. Hi, thank you so much. I was wondering if the physicians that you had interviewed were private practice or public, and when you were reviewing literature, if you found any difference in burnout, how they describe burnout between the two, perhaps?
That's a great question. So I didn't interview the physicians. They submitted the reflections themselves. I don't know if that's helpful, but they were both working at public hospitals. And for the literature, I don't know about that. That's a great question, and I should look into that. Thank you.
Any other questions? Okay, thank you so much.
Oh, no, there's one. No, go for it.
When you talked about the patient not really getting sick or recovery, were you speaking in terms of the actual cardiac failure and the surgical procedure or the substance use disorder or both?
From the procedure, yeah. He stated that he was not able to recover fully from the surgery. He was back in prison before he was feeling fully recovered from the procedure that he had just gotten.
I just think that that's obviously a big surgery and there's a lot of pain associated with it.
Yeah.
So for someone who has a history of opioid use disorder to sort of not be offered full recovery would be equally traumatic for both of those conditions.
Absolutely.
And I know or justice involved patients have a lot of trouble getting buprenorphine and access to those medications and
Yeah.
pain medications. And so it's not surprising to me that ended up being the case.
Absolutely, that's something he reported to for all kinds of medication. When he was talking about accessing healthcare in prison, he was having a lot of trouble getting to see a doctor. In fact, he had symptoms from the final case for a couple of weeks before he was brought in, and he tried to see a provider again and again. He tried to get on a list and was not able to get on it. So he went through several processes in prison to get access to healthcare. Any other questions? Okay.
Thank you, Sid. So we'll take a 15-minute break. If we can all come back at 2:15.